Welcome to the Green Nurse Podcast, where we bring hope and inspiration for growth and healing. We're here to change the dialogue and stigma around what it means to feel good or be high, hence the H for hope, I for inspiration, G for growth, and H for healing. You deserve to feel good. We all deserve to feel good. And here is what we do in the cannabis space as nurses. And then we're going to get started on our very special show. All right, partners in health, here we come.
Change the paradigm of healthcare.
The Green Nurse is a holistic cannabis nurse that teaches on the endocannabinoid system and the safe utilization of cannabis and other progressive tools to help people reach a better quality of life.
I'm the founder of Holistic Caring. We're based here in California, and we do educational programs and case management for patients on how to use cannabis therapeutically as a medicine.
We're also here to decrease stigma around what it means to feel good and be high, hence the H for hope, I for inspiration, G for growth, and H for healing.
As the founder of Holistic Caring, I basically oversee the whole ship, and what we're doing is progressive education.
Cannabis actually supports all 11 organ systems, our immune system, and all the neurotransmitter signaling systems that give messages to tell our body to either do something or not do something. Because the plant was prohibited, it prevented health professionals, doctors and nurses from learning about cannabis as medicine.
I want to change the paradigm of healthcare, and us paving the way into a new vanguard of medicine.
It's about education, it's about empowerment, it's about teaching people how to feel good, bridging the gap from what they're not getting from traditional medicine, utilizing different plant medicines, adaptogens, tips, tricks, hugs, and nugs of information to support and nourish the most important system in our body.
And it's a lot of soul work, a lot of love, a lot of discipline, and meditation. I'm using my life work as a testimony to others to learn how they can be their own hero and then go help heal the world.
And we are, as nurses, the game changers.
Well, there you go. Where you have it right there. Growing in health, growing in cannabis. My name is Sherry Mack, and I'm the Vice President of Nursing and co-founder of Holistic Caring and the Green Nurse. And I am a cannabis nurse, cannabis patient, advocate, activist, and a very passionate podcaster here to change the paradigm of healthcare with my partner here. And I'm really, really excited to announce that this is my 7th year podcasting The Green Nurse Living Your Best Life. Started podcasting in 2018 when the National Council State Boards of Nursing came out with their guidelines that all nurses must have 6 essential areas of knowledge when it comes to cannabis as medicine. I started podcasting to share those compelling stories of healing and to decrease stigma, since I too use cannabis as medicine. But before we get started on our very exciting show with a psychiatrist who specializes in cannabis therapeutics, we have a message from our sponsors at Bloom Hemp being shared by Elizabeth Mack, my co-host and our CEO. So Elizabeth, tell us all about Bloom Hemp.
Well, Bloom Hemp is a woman and nurse-owned hemp CBD supplier from the mountains of Colorado, leading with quality, safety, value, and patient-centered care. All Bloom Hemp products are USDA organic CBD, tested for purity, potency, cannabinoid, and terpene profiles. And Bloom Hemp is proud to offer a free nurse line for every patient, 970-404-HOPE, or you can email info@bloomhemp.com, or go to the services tab and click intake and start your free assessment. So a nurse will reply with your free care plan, because every patient deserves a nurse.
There we go. There you go. Thank you, Bloom Hemp.
All right.
And we are back here. So as you all know, cannabis nursing has been recognized as a specialty, and nurses are truly making an impact on advocating for the safe therapeutic use of cannabis. And today's guest is a doctor of psychiatry who is paving the way for other psychiatrists and mental health practitioners. Dr. Mark Viner is a board-certified MD practicing in Nevada for over 30 years. He attended the University of Southern California and Yale University. He has been a professor at both the University of Connecticut and University of Nevada School of Medicine. He has received the National Alliance for Mentally Ill Exemplary Award twice for his work in mental health and substance use. He has expertise in cannabis medicine for the past 6 years, and as an active and contributing member of the Society of Cannabis Clinicians, Dr. Viner has contributed to the advancement of the field of cannabis medicine. And so today we are excited to have him share his expertise on safe consumption for mental health and to shed light on what psychiatrists really think about cannabis and psychedelics and how he's working in the plant medicine arena today. So welcome to the show, Dr. Viner. We are so excited to have you here.
Thank you. It's great to be here.
Yeah, it's just so interesting. Mental health is such an important issue of healing, right? Do we really put the care into mental health the way we should?
Or even physical health.
And even
but
physical
mental
health.
health is really hard.
Yeah, I mean, you think about, in the conventional system, what do? We focus on body parts. If we're lucky, we get to mental, emotional health. Rarely do we get to spiritual health, but we're focusing on parts. So how do we really need to come together? And cannabis is such an amazing plant, and we want to know, what do psychiatrists really think about cannabis?
Well, and what's your story?
It's interesting that you said, because because with mental health, if you think about the endocannabinoid system, and where the areas in the brain are rich in cannabinoid receptors, you could see how we need to discuss emotional homeostasis as well. So how I've gone through DSM-5, and cannabinoids could be involved in every mental disorder listed in some way or another. The rich receptors in the basal ganglia, for example, and in the hypothalamus, and all of these are related to the mental health disorders and the intimate role endocannabinoids have in those areas. So I don't think you can talk about cannabis without including a large portion of information about mental health and psychiatric disorders. But there's a very little, if any, psychiatrists out there that can discuss it, and because it's such a hard topic. For example, with anxiety, you got to know the relation between the neurologic, the immunologic, and the endocrine system to explain how cannabinoids might help anxiety or affect anxiety. And that's a very difficult topic because psychiatrists don't know about immunology and immunologists don't know about psychiatry. But as we advance our knowledge in these disorders, we're seeing more unified pathophysiologies and etiologies, like with cancer and stress, as an example. So how I got started, to answer your second question, I've been a long-standing mainstream psychiatrist. I started in the old state hospitals with the terrible treatment. In fact, where I trained in Norwich, Connecticut, they demolished the building and it's haunted. They said it's haunted. I'd seen all the terrible way they treated mentally ill patients. And then I worked in the state hospital because of my background in medicine with clozapine, which really is the only med that helps schizophrenia, that can get a patient out of the institution and functioning. But it's very hard medically to prescribe and monitor. And then I practiced at the state hospital and taught at the university for 20 some years, did some private practice. And then the local politicians asked me to be on a panel about the feasibility of medical marijuana in Nevada. And I was the only doctor in 2016 to even could talk about it. So in there, my interests have increased in cannabis, in plant medicine, and psychiatry with cannabis.
Cool.
Very good.
Yeah, I remember those old days in psychiatry. I started in 1987 at Heinz VA Hospital in Chicago, working with serious mental illness and in the veteran population. A lot of PTSD, a lot of bipolar, a lot of drugs, of course, coping with the return home from Vietnam and the things that those gentlemen had to endure. The suffering is something that we hope to stop with the endocannabinoid system as we're talking about it, and I can't wait to dig a little bit deeper.
Yeah. Yeah. So what is the current mainstream view of cannabis by psychiatrists?
Well, mainstream view is there's no role. Oh my God, it's going to cause anxiety. What are you doing? You're going to make everyone psychotic. It doesn't help bipolar. Everyone's going to become an addict. How dare you even mention it? There's limited, if any, proof that it harms you. So you're going to have to sift through all that. And then you'll find a few real hardcore, people who did specialize in schizophrenia and catatonia, catatonic behavior. Now, you must hike and this kind of stuff to really understand how, and anxiety and nearly every mental disorder, the endocannabinoid, think about it, it calms you down. So if your glutamate is firing excitatory neurotransmitter, then THC decreases that firing and you can't process, then, that might be beneficial in some sick patients who need fear memory extinction, for example. So, it all depends on who you're treating and what you're treating or trying to help the patient with. So the nurses are going to be in the forefront. As a psychiatrist, I'll need nurses to be able to assess these patients, and if that's going to be done. And then nothing can beat having great nurses as a physician. So I like to do educational work with them and help train them.
Nice.
Well, thank you.
Yeah.
We talk a lot about serious mental illness, right? Schizophrenia, bipolar. Those are normally, waivers or exceptions to the medical cannabis rule that most doctors are writing the recommendation. If you have schizophrenia, bipolar, mania, etc., you're not going to get a card. You're not going to do psychedelics. Your plant medicine is kind of not for you. But if we would shift over to anxiety and depression and coping with life, and just really tapping down that glutamate and it's stimulating GABA and helping us relax and finding that balance. Now, our mainstream psychiatrists doing that at least, or saying, from a harm reduction standpoint, for somebody who's depressed or somebody who's very anxious, but without the cognitive issues, are they in favor of that at all?
Well, the literature's out there about harm reduction with opiates, but they're also with antidepressants and anti-anxiety meds. So, and most commonly it's used for anxiety, depression, and insomnia. So I like some of the work with THC was is an antidepressant in some ways. And CBD, if you're anxious and depressed, can help that. So anxiety, depression, insomnia, they still would not recommend it. But I think you should have a bottle of THC in a sleep lab so you can induce REM suppression, and just think of the wealth of information you get with sleep-wake disorders, all those behavioral disturbances at night, everything from Parkinson's down to just restless leg. So you got to look at anxiety. It's complicated. There's a motor going towards or away from something, avoidance or reward. All the cannabinoid receptors are in the basal ganglia. And my favorite are in the hypothalamus, where you have sleep, wake, eating disorders. Nobody talks about that. You see the current a fad for the weight loss drug, but THCV might be a safer alternative than injecting or so with the. So I'd love, sleep wake eating disorders. There's sexual disorders, anxiety. For anxiety, you need to understand the limbic system and all the cannabinoid receptors, and it helps by calming down an overactivated areas of the brain, or it functionally connects areas of the brain that are weakly connected. So, but you got to really understand the pathophysiology of depression, the modern version, not the monoamine hypothesis with neurotransmitters. You have to know neuroimmunoendocrinology, how the stress, the parental separation, it methylates the kid's DNA, and then later on his hippocampus is small, so when there's stress he freaks out. All of that is the endocannabinoids related to all of those steps. So unless we modernize our knowledge of psychiatry, it's going to be hard to integrate cannabis medicine into mainstream psychiatry. But there's more and more literature with everyday living, and how to improve, incorporate it into a wellness plan. I guess you have to take that shot the rest of your life. If you did some plant medicine and then incorporate a diet and exercise and keep that going, boom, that sounds a lot safer. So, yeah.
Well, we all know the drivers of health live outside the conventional system and are modifiable by us. So teaching people how to use cannabinoids to eat better, right?
Yeah.
To facilitate the relaxation response, how that they can utilize cannabinoids to help them to earth, to ground, to meditate, to utilize cannabinoids for other health and wellness activities, to modulate, because we know the endocannabinoid system signals both the fight or flight response and the relaxation response. Well, guess where we heal better? We all heal better when we're in the relaxation response, right? Generally, 9 times out of 10, we're all running around with our hair on fire, right?
Well,
Pretty much.
I don't know.
Well, the amygdala, is increased in size. The amygdala and anxiety and threat and fear, like living in Pennsylvania and downtown, the city where people get shot. Okay, their amygdala is swollen and big, but if you walk in a forest for a half hour, it shrinks down. And there's so many rich cannabinoid receptors in that fear, threat area that, it's no wonder why people use it to relax, not euphoria. The number one reported feeling is relaxation. So for anxiety, but you got to be careful. You can't just yank someone off benzodiazepines cold turkey. There's really new literature that they could die from that. So I'm against benzos, and if you could replace it with, an indica gummy bear, great. But I need a nurse helping me with the benzo part. You got to be careful. You can't just switch and think everything's going to be wonderful if they've been on 8 milligrams for 20 years.
Yeah.
So
For the most part,
lorazepam.
for the most part, when we're working with patients, it's taking the cannabinoids to bridge the gap from what conventional care isn't providing. And then the doctor makes the recommendations to wean down the pharmaceuticals.
Yeah.
And we help them to titrate the cannabinoids to.
Yes.
It's always a stair-step approach. Most people find us as nurse case managers because nothing else is working, right? And the point is they're on the 8 milligrams of lorazepam a day and all the other antidepressants, and then sometimes Abilify and Lexapro and Seroquel for sleep and all of it, right? And they'll come to us and say, I can't take these drugs anymore. I physically can't stand it. And so we'll start them on some low-dose CBD just to make everything work a little bit better, and then say, here are the observations you need to look out for, and then go back to your physician and say, here's the conversation I need to have about a weaning structure. because I need
Very
my
important. That's
Yeah.
really important because I spent 20, 30 years seeing a patient in the psychiatric emergency room and seeing a list of like 20 psych meds. And I go, no wonder why he's here. And I made a living off of tapering them off. And I would literally, sorry, I'd literally sit there and go, you're not going to need this one. You're not going to need this one. You're going to need this one. These three are the same thing. And, you know, it would be great to watch him get better just by, but see, that's sloppy psychopharmacology. I mean, I was a psychopharmacologist. All my publications were on medications. So, you know, there's a lot of sloppy, lousy prescribing of psych meds that the whole profession gets blamed for, like me, whereas I made a living getting them off, helping them reduce it. So good point. And it's important they go back to the psychiatrists so they can be in the loop. They're not going to freak out. They'll freak out more if you don't tell them.
Right.
Yeah.
That's worse.
The other thing too, that for these prescriptions, these antidepressants, anti-anxiety agents, pharmaceuticals in general, I'm not anti-pharma. I'm about being pharmaceutically aware and pharmaceutically responsible. About the drug nutrient depletion, right? And how a lot of some of these antidepressants causes damage to even DNA in the brain that we've seen over time, and how drug nutrient depletion. So certain pharmaceuticals, actually, if you're taking 5 or more pharmaceuticals, it's considered to be 50% chance of drugs interacting. If you're taking 10 or more, 100%. But a lot of the pharmaceuticals that are prescribed deplete the body of B vitamins. And we know that B vitamins bathe the central nervous system, right? So when we're anxious, B vitamins can calm us down. And when we're tired, B vitamins can perk us up. And a lot of pharmaceuticals that are being prescribed, I look at patients that come to us and they're on all these pharmaceuticals and they're not taking any supplements and they're not eating the foods that they need to be taking to mitigate those side effects of drug nutrient depletion.
Well, yeah. I mean, one of the best, most refreshing things to see is to be able to, when you see a good response with, say, tetrahydrocannabinol and THCV, you can get them off their metformin and all these terrible, horrible things. But some you got to keep them on them, like some of their blood pressure med. You got to be careful. So yes, and they don't promote plant medicine, right? I find the opiate, the pain pill companies are real against cannabis. And I was wondering, why are they so, because it helps pain and, it's a competitor probably. So you're going to see all kinds of articles published where the authors are speakers for the opiates. That's a good example. But antidepressants, I agree that the whole ketamine doesn't even work on those neurotransmitters. It causes a massive growth of the brain areas with dendritic growth and sprouting quickly. It doesn't wait for dopamine, serotonin to
Ketamine.
So that's important because I find I compare cannabis to ketamine a lot, and I think the cannabis is a lot safer because in addition to sprouting neurons, you can sprout other things in the body. So like breast cancer cells, there's a few articles that it can worsen cancer cell growth. So, the whole thing, you got to really know what you're doing and be careful and have a doctor, have the nurses work with the doctor, and the patient will do well usually.
Yeah. So were you speaking about ketamine causing some of these side effects?
Yes, the ketamine is often, cannabis used to be clumped in with the hallucinogens like ketamine, PCP, LSD, psilocybin, but it was taken out of the hallucinogen category several years ago in DSM-5 and given its own little category like nicotine, like tobacco, alcohol, stimulants. So it's not considered a hallucinogen. So cannabis. So
Okay.
I find the comparison is great when we compare cannabinoid plant medicine to hallucinogens. Very interesting topic.
Yeah, for sure. And cannabis is a lot safer, but when you think about treatment-resistant depression, where ketamine is an off-label use, and you've got these ketamine clinics sprouting up all over the place, and doctors and therapists lining up to get certified to do it, it's because there's a monetization pathway. Whereas cannabis, people can grow their own, go outside, have a joint, look at nature, and feel better, and nobody gets rich off of it. Right. And so,
or hurt, because they also do it by tele with no psychiatrist on premise. And you need someone to manage the tachyarrhythmia and psychosis, suicidality that can occur on site. So it's not all, but there are some good psychiatrists. Like I turned a position down because I'm not comfortable doing that, frankly, at all. It's FDA approved for anesthesia, not for psychiatry. S-ketamine by Janssen, nasal spray is approved in psychiatry. So, I'm a board certified, so I have certain criteria I got to stick to. And that's really discouraged by some people, even more than cannabis, perhaps.
Well, that's going to be my next question now that we're on to psychedelics. What do the conventional psychiatrists think about the psychedelics? We're in a psychedelic renaissance. Well, with the microdosing, we're seeing LSD, we're seeing a lot, and we're seeing a lot also in Europe.
Are they just as opposed to microdosing psychedelics or psilocybin as they are opposed to cannabis?
No, it's weird. It's like cannabis is like the dirty cousin. It's getting blamed for everything because it was withheld and you couldn't do any research. They're really rapidly approving clinical trial advancement with both psilocybin and MDMA in the PTSD and depression realm. And I recently saw one just for social anxiety. So as a psychiatrist specializing in psychosis, I don't want to make the patient psychotic. If you give too much, you're going to get psychotic, like the guy on the airplane that freaked out and opened the door, or there's numerous. So anyway, I'm more of a cannabis person because it's safer. They're not going to have all that problem with cannabis. And, so, I agree with treatment-resistant depressed patients. Those are like your last choice. They can do ketamine and ECT at the same time. That's crazy.
No way.
It depends what kind of, like a Boston University, not, at some clinic. You got to be in a major teaching hospital. That was published, I think, at Harvard. They tried that. So anyway, the psychedelics are getting rapidly approved. They're not really they get plugged into really appropriate clinical trials that are well thought out. So they can say phase 1, yes, phase 2, yes, phase 3, yes. Cannabis is still left in the dark. They don't even, do we use oral? Do we use Marinol? Okay, I saw a study on Marinol for COPD. Well, obviously, if you take a Marinol, that's not going to help COPD. If you got to do it's just ridiculous. So they're way behind because they were out front first. And I wouldn't like to see them fused. There's too much information with cannabis that isn't known. Like there's nothing in psychiatry at the next cannabis convention. You'll have a pediatrician talk about Tourette's or ADD. You need a child psychiatrist that knows substance use also to discuss that. So there's way too much in cannabis missing than to fuse it all together, in my view.
Yeah, agreed. And I'm thinking about the advocacy groups that are supporting both, right? You've got MAPS that is, founded in 1986, raised over $150 million directly going into this and helping these companies get traction so that they can fund the clinical trials, and they're all funded. As opposed to Normal and ASA, right? So we know, the National Association or the Organization for the Reform of Marijuana Laws, working to get people out of jail, overturning convictions, getting people back into the employment market, and they're both valid, but the clinical is being pushed by MAPS and the psychedelics as opposed to cannabis. We've been at this 9 years each, and still hardly getting anywhere because cannabis is that dirty secret that people don't want to talk about, other than just chill out and smoke a little bit or get some edibles, which could cause the psychosis, right? With 100 milligram edible chocolate bar, what's happening in the brain? Right? If somebody eats the whole 100 milligram chocolate bar, what's going on in the brain? If you could break that down for us, I think our show would be very interested.
Well, remember when the 500 milligram bar came out before they knew anything? Okay, you're going to activate it depends if they're chronic users or acute users for one. Okay. So let's say they're, it's their first, they're going to activate the fear center. It's too much at once, which is similar to the psychotic area for psychosis. So you get too much, you get anxious, paranoid, psychotic-like symptoms. But frankly, the psychosis is mostly with the stronger and vulnerable people that do a high dose. Almost, synthetics cause THC will cause this psychosis. So, but if it's some of the regular stuff that goes around, I think a lot of it's mislabeled psychotic. For example, it's misdiagnosed as a delirium is mixed up with psychosis, dissociation, catatonia, all these regular intoxication with perceptual disturbances, with intact reality testing. If you have a cannabis-induced psychosis, it should be a cannabis-induced psychotic disorder. So that's more serious, and you'll see that, sure. And, my goal is to help, how do you treat it and all that. So you got to be really careful ingesting, and it takes a while to kick in, of course, so you don't think anything's wrong at first. So you just eat the whole 500 milligram bar.
THC we're talking about. We want for our viewers, we want our viewers to know we're talking about high THC products, a 500 milligram THC candy bar. If you eat that is going to, and plus that also too, THC actually does scrub the 5-HT2A receptors, the psychedelic receptors, right? So we know that if you take THC with psychedelics, it's going to enhance the psychedelic experience. Correct?
Yes. There's great studies on, they studied people. There's a great article on both, people who use both at the same time, and they published all the findings. So yes, there is some synergy there and interactions, definitely. Well, CBD is often overlooked because if you're needing that to relax, I consider that as the yang of THC, yin yang. It's more sedating. I hate to say it's almost like a sedative, hypnotic, but safer than a true one like a benzo or a Z drug. But that's acts on the serotonin receptors as well. So you gotta look at. I've seen some depression with CBD and hypomania and agitation, psychotic-like anxiety, panic with THC. That's why I wish they could put them back together more. I know it's
right. Put them back together. Yeah. Well, we have a question from our audience. So someone has written that, what about people that have been using cannabis for years for anxiety and depression, and then all of a sudden they develop cannabis hyperemesis syndrome?
Yes. Okay, it's real. I believe it's real. You'll end up with the appendectomy and a normal appendix because it fooled the doc. That's what happened in the old days before it was described in the literature. You blame it on the munchies and eat all these food, then you get this bad nausea, vomit, and then you end up in the ER. They don't know what's wrong. You get an appendectomy. So, you know, you got to really watch it. It's you got to, the cold showers, of course, you've heard about, but you know, I'm worried about the complications like dehydration, renal insufficiency. There's some more serious complications from the vomiting. And so think about it. Why would you give Haldol for that? That's fascinating. Not many people mention that, but there's a reason.
Antipsychotic.
Yeah.
Antipsychotic.
So yeah, there's about 5 minutes.
Remember compazine? Compazine rectally is Thorazine, an antipsychotic, but it's for nausea and vomit. Remember compazine for nausea and vomiting?
Yeah.
So, but you're going to have to, I don't think you have to stop it forever, but you got to quit for a while, you know, go back to hold it for a while and maybe re-challenge. They say use less THC, blah, 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 mostly CBD, but you know, you got to watch. I'm worried about the medical sequela of that not being seen in the ER or actually being treated, because you got to rule out other stuff too. I mean, they'll take you to do exploratory surgery in the old days for something like that. So you better be upfront and tell them what's wrong, because there's some exotic treatments like that. Weird, huh? It might work. I've read reports. And all kinds of, you need IV fluids for dehydration. You know, it's something you got to look at, but don't get depressed and say, oh God, I'll never be able to do it again, ever, ever, ever. I think that's a little bit of a misnomer.
So you mentioned, this is another subject. Do you want to continue on CHS?
No, we don't see CHS with CBD.
No,
That's
and
what
we don't see CHS with a lot of our medical patients that we are helping to really use CBD,
Right.
CBG, CBN, THCV in the mainstay, and then just microdoses of THC as needed. Because most patients don't need as much THC as they think they need.
Exactly.
Right, exactly.
Because if you think about when we're producing, right? So when the body makes the anandamide molecule, just like the THC molecule, it's not as strong, right? The THC molecule is much stronger than our anandamide molecule. And we create that molecule upon demand, and it's nudging a receptor. It's not plugging in as tightly as the THC.
Yeah.
When we consume it.
Now in psychiatry, we have to get more comfortable with THC in psychiatry, because all of your movement disorders, tics, Tourette's, everything THC is gonna be needed in the basal gang, for the locomotion. The anxiety we talked about, and for obsessive compulsive recurrent thoughts over and over, you can't get out of your head, you're going to have to extinguish some of that. We got to be more comfortable with THC. But you're right, the THC, people don't think it works in the brain stem. They always say there's no receptors in the brain, but the nausea and vomiting is partly in the brain stem, the hyperemesis. That shows you how powerful of a GI med THC is. And I've seen when they rectally use it, all kinds of motility. It almost reminds me of a little bit like Ozempic, that GLP-1 agonist, terrible side effects. So you got to watch THC in the GI tract. It was used for dysentery in the old days. So it has a lot of different GI side effects, whether taken orally, rectally, and the mesenteric lymph nodes get totally absorbed with it. So when they want to use animal feed animals with it. I'm worried about their mesenteric, when they sacrifice the animal if it ate a bunch of CBD its whole life. We need more microbial studies in animals with that. So anyway, THC, yeah, the brain stem, and it's also in the disgust center, the insular area in the brain. It's loaded with cannabinoids. So that nausea, vomiting, and disgust type of, like, you know what I mean? You'll see that with olfactory and PTSD. It's all totally saturated with cannabinoid receptors for either endocannabinoids to produce that the body can produce, or they could be perturbed by the exocannabinoids, the products. Mm-hmm.
Yeah. And I wanted to discuss a little bit about CBD and THC, and then also the enzymes that break them down, because we talk a lot in cannabis medicine as these compounds from the plant nudge the same receptors as our endogenous compounds, anandamide and 2-AG. However, the enzymes Fa and Mogul that break them down don't break down the plant. Right. So we need to have that go through literally pharmaceutical pharmacokinetics and absorption, metabolism, excretion, as opposed to, having enzymes to break them down, which is why it's 10 times stronger and lasts 10 times longer.
Right. Because we have enzymes that create the endocannabinoids and the enzymes that break them down. So when we're taking cannabis, enzymes aren't touching the cannabis compounds.
Right.
We have to go through.
You know what else? And you know what I find fascinating is you can train the skin you don't necessarily have to absorb the whole thing. I think it on the surface of the skin, it goes right into the brain, signals right into the brain. And that's why you'll see it with massage therapy as a cream. It's very nice. Or the nurses used to do wet packs to calm patients in the mental institutions in the 40s. They would wrap them up in sheets in a wet pack. So you could use, the skin can be trained to affect and go into the brain. And there's a whole science that the cosmetic industry uses to measure the tension in the skin. It goes right into the sensory cortex of the brain. So the cannabinoids can also be acted by the system by light. It's a GPCR rhodopsin receptor, the body's receptors that are activated by light. So someday I fantasize about, we won't need to smoke, eat, ingest, hurt ourselves smoking so much, when it's crazy, but you can walk into a room, shine a certain UV light and activate your cannabinoid receptors without having to do anything. That's like maybe in 100 years from now, but they're doing that with mice with GPCR receptors. They can illuminate the mouse's eyes. Have you seen those fluorescent mice? They're in science journals. So it's the same type of receptor. So very fascinating. Yes. Not necessarily having to metabolize. Right. Exactly.
Yeah. So you mentioned, CBD can cause a little bit of depression. THC can cause a little bit of mania. Can you elaborate a little bit more on that? Because maybe that's why some of the psychiatrists are anathema to this. They're not wanting people to expose themselves, and then play dosing, because everything we know is about dosing and the biphasic natures.
Right. The mania, it's bipolar is really the brain's inability to stop oscillating at frequencies in about 7 different areas. So once you're manic, it's not going to really help, it's too late. Everything's running, oscillating, and won't shut off. I've treated so many manic patients in my life. I believe that theory. So a little CBD, none of that. It's not going to help stop the mania. The way to help the bipolar with cannabinoids might be way earlier when they start not sleeping well first. So you might give them some CBD so they sleep or whatever, THC, cannabinoid preparation to help them sleep early, way before they're manic and it's too late.
Right.
So you got to explain how it can help restore, and it's really the circadian rhythm, light, dark, it's all right there in the suprachiasmatic nucleus with the sunlight. That's why you want to incorporate cannabis into a well plan with walking, going to bed at the right time, waking up and getting that AM sunlight for 30 seconds. You got the cannabis can help you get out and do stuff like that. So anyway, the mania. So I don't know. The THC I haven't seen mania. I've seen acute anxiety or agitation. Catatonic excitement scares people, but there's a mild version. But it's not a classic mania per se. In fact, there's studies that show it helps manics actually focus a little better, but don't do that. Don't use it for that.
Right.
Now,
So
and
very
the
low dose.
CBD, yeah. The low dose was calming, but high dose THC is activating. Yes.
Yeah.
Now
So
the CBD Now it's very confusing because if you don't divide depression into subgroups, you won't understand. There's melancholic depression. There's we'll make it simpler. Melancholic, anxious depression. There's all kinds. Postpartum depression, seasonal depression, bipolar depression, psychotic depression, late life depression, cognitive depression, from dementia. So you got to know what kind of depression. If you have the anxious depression, it'll help most likely. Duh. Okay. But if you have melancholic depression, late life depression, like anhedonic depression, fatigue, no energy, then I don't like CBD for that because I think it's the yang of THC. It screws up the circadian rhythm, light dark cycles. I'm a little hesitant about those kind of depressions. But for psychotic depression and anxious depression, sure, it probably might help a little. But you got to know if it's a psychotic depression, you don't want to give THC, right? How about perimenopause? Or how about perimenstrual psychosis and depression? You want to lower the THC because the girl will get more psychotic around the period or perimenopausal. So I like personalizing the cannabis treatment for stuff just like that. It all has to do with the circadian rhythm and the hypothalamus, which gets all that information. And what the cannabis receptors are very dense there, very dense.
Hypothalamus. So what's the best time to go to bed? Would you speak about
If
circadian?
you want to phase, if you're flying to the East Coast or flying back to West Coast, you could adjust, and so you don't get that phase shift. But the younger people stay up later, and the older people go to bed earlier. So it depends how old you are and where you are in your life and what you want to do, and you can change it with stuff like that and help your rhythm, your circadian rhythm. For an older person like myself, I like going to bed earlier and getting up earlier because I love that morning sunlight. Because I sat in a hospital for 40 years in a desk or in an ICU, so I'm doing things that I haven't been able to do my whole life, like walk a lot, get that morning sunlight, make sure I get good rest, and have very good, just change the diet, that kind of stuff. So
because one of the reasons I asked is because insomnia is one of the reasons that people use cannabis, CBD and THC, as much as pain, right? I need it to help me not hurt and to sleep. So what's the best? What do you give people when they're like, I'm not sleeping? And I know you're going to go down a rabbit hole with why and what is the sleep? Why the sleepiness? Which is what most doctors should be asking, but.
Well, there's so many different causes of insomnia. Sleep-wake disorders. Is it an older patient with Parkinson that's getting up and thrashing around? You want THC for that to suppress the REM activity. Okay, or is it a bedwetting child? There's all kinds of literature. Okay, or do you just are you anxious? You can't, did I screw up at work today? What about that other patient? What am I going to do about the bill? So some people might find some relief with CBD like that for anxiolysis and insomnia. But I'm cautious about having people just jump, because the mainstream psychiatry will say, no, you're going to cause a cannabis use disorder. You're going to get them hooked, because imagine, the withdrawal is nasty. The sleep, if you just lowering your THC, it can cause really bad sleep disruption. So they're going to say, oh my God, what are you doing? You're going to get them hooked on this. It's a sleep aid. So, that's what a lot of people think. But again, you got to know, is it obstructive sleep apnea? Because THC has been shown to help that. Or is it, or obesity? Maybe THCV would be good, a higher, to cause some weight loss. So it all depends on what the insomnia is. So it's like dementia, there's 15 different types. So I really think with cannabis, if you're serious, you got to know which type to address the product and the dose and the ratio and the strain and all that.
Also, do you have difficulty falling asleep, staying asleep? Do you wake up frequently? Do you have nightmares, right? So those are all of those different things. How do you start your day? So when someone has a sleep issue, I want to know, exactly like you said, what do you do in the morning? Because your sleep hygiene begins the minute you open up your eyes.
Right.
What you do all day long is going to affect how you sleep at night. What you eat, what you drink, the supplements you take, and even the cannabis products that you take in the morning and in the afternoon are going to affect your sleep at night. So looking at everything.
Yeah, and we have a question in, what about CBG for sleep? And, I know Healer is promoting a lot of CBG for sleep and saying it really quells anxiety. So if you're an anxious insomnia, then maybe CBG before bedtime would be helpful. What do you say about that?
Well, as a psychiatrist, I think it's a very good antidepressant effect for some people, but I mixed with the THC. I know that sounds terrible, but a 5 milligram THC / 5 milligram CBG is real hell. I've seen it really help depressive symptoms and anxiety. But maybe I think it's counterintuitive to use it with CBD, but it makes sense. But in psychiatry, when I want them to perk up and not, maybe not need the Prozac as much, or get rid of the 4 different maybe you can cut back. The CBG is I like it. I'm impressed for depression and anxiety and pain. And I like mixing it with the THC. Sorry.
Yeah, me too. And they're both CB2 agonists, right? So if we want to calm neuroinflammation and perk up mood, CBD or THC, CBG is a great combo.
And with the older folks too, a lot of times what we'll do is we'll get a combination gummy that has THC and CBG in it, and we cut them in quarters for the daytime, and then in the nighttime, THC and CBN gummies. cutting and quarters. So
Yeah.
these are for the older
Yeah.
folks. So they're
Yeah,
perked
yeah,
up
that's
time, right? Their
Mhm.
their stress
And they
response is
can
being
get up. Yeah.
they can
And they
function.
get up and their appetite's good and they can move around more and they're
Yeah.
more involved. Yeah, definitely.
Yeah, and we've only got a few minutes left, and I wanted to see if we could pivot a little bit to neurodegenerative conditions, right? So Alzheimer's,
Yeah.
Parkinson's, MS. We talked a little bit about this, but aiding, eating, sleeping, moving, mobility, appetite, and really and limiting pain. So how about later in life and neurodegenerative disorders?
Yes. I like what you mentioned were great effects. And I'm a little careful with dosing and and caution of the side effects like falling. You got to be careful. Sometimes there's agitation if it's too high of a dose in elderly. Um, the senile purpura. This is where nursing is important. I want my nurses to do a physical, a limited physical, and check their skin, their arms. The skin and the brain are the same embryologic tissue, so it'll tell you a lot examining the skin of a elder cannabis patient. So if they're mixing Motrin, they're taking 4 Motrin, and you got to watch make sure they're not bleeding or bruising with the products. So aside from that, it's great. Like instead of opiates that constipate, there's not much constipation with cannabis. So a lot of the elderly like that. It's like pain relief, and you don't need a colectomy because your GI tract shut down from opiates. So, I do watch certain things, and I'm careful with dosing, usually half the dose for a healthier person. But I think it's really going to be important, and you'll get more lobbying and support when the nursing homes see it use and help. And then the hospitals, they're a good lobbying source. So once it's allowed in the hospitals and they see it, nurses using it and it's helping, we'll get more cannabis support for the elderly. But yeah, I've seen it really improve their quality of life, everything. But again, they think they need to get monitored because imagine trying to figure out the dose. How is an old person supposed to be able to read they can't even read I can't even see the label half the time. And they're going to run into trouble. And what happens is they'll get labeled by mainstream. Oh, you're an addict. A poor 78-year-old who's just wanted to try it gets labeled on her Medicare, that she's a cannabis use disorder with and they're going to discriminate like they do with smoking, like COPD. So you got to really monitor. It doesn't need to be a doctor, a nurse. It doesn't even need to be a nurse. Just someone that can check a relative, like they do with opiates in Utah. If it's an older person, someone has to be at home that's familiar with the drug and watch them take it. You got to just be, if you're running into trouble with safety issues, but it could be real miraculous for older patients.
Well,
and
for sure.
neurodevelopment, and don't forget the neurodevelopmentally disordered infants and children. Not a healthy child that's happy, adjusted in sports, has girlfriends, straight A's. I mean the abused, neglected child with PTSD or has trauma about childbirth because the opiate husband. I've seen everything. These you got to see their childhood neurodevelopmental as well as the neurodegenerative, because one is when you've learned the material, then lose it, and the other is just learning the material. So I think there's a lot of overlap there. Encephalopathies, like inflammatory Tourette's, and OCD, and you can see encephalopathies in elderly people from neuroinflammation. And it's such a strong anti-inflammatory that obviously, we didn't talk about the microglia and the immunologic effects, but they're so profound. And in order to do clinical trials, I feel you've got to monitor the inflammatory and immune markers if you're using medical, using it in medicine. But generally for the regular user, recreational, you don't have to worry as much. But if you're using it in a clinical study for a neurodegenerative disorder, I think it's fruitful to monitor inflammatory markers, for example.
Well, for sure. Yeah. And we always start people, out with, 1 to 2 milligrams of THC, no more than that, balanced with CBD. You got to have CBD on board to help, modulate that CB1 receptor. So it's not too much. You don't want them to say, I'm never going to do this again, because it could be very therapeutic for that neuroinflammation and for a lot of the aging issues. So for sure.
Yeah.
So one more question.
One more question. This has been a great show. Wanted to know, this is just a personal question. What is your favorite strain name and why? Strain name and why?
What's your favorite
strain name? It's just a fun question. And what strains do you feel are useful in psychiatry? What strains?
Okay, the strains have to be grown on the equator. And the inflorescence has to be grown on the equator. So South America, like Durban poison and Malawali and those. And then you've got your the Thailand, like Thai sticks, brought in the 70s because of the Vietnam War. That stuff blows away the current stuff that's available, by the way. The Thai stick, and then there's Colombia. So the reason why is that's where the earth spins the fastest, and they grow the tallest, and they got the leaves and the sativa landrace strains in the equator, like Ethiopia. Everything the Africans that are all thin and work 20 hours in the field, none of them have diabetes, obesity, metabolic syndrome, hypercholesterol, and it's rich in THC and THCV, but you got to have the others with it. You can't just do that. And those are my very favorite ones in psychiatry. I don't like I use the Afghani and the northern landrace strains up north less, but because I see a lot of depression and just but those are good for sedation and anxiolysis. So it's very important. I hope someday as a doctor I could get access to those international strains. I need some of that for some of my obese, diabetic, so they all don't go on some fad and get sicker with trying to lose weight. So I like those activating ones at the equator. That's where they have the geisha coffee, that very strong coffee. So, if you mix some cannabinoid from there with some of that geisha coffee, boy, that's better than side effects there, effects, Venlafax. That's could be a lot safer, and I've seen some good results, but that's far in the future, probably.
Yeah. So if you were to have a closing thought to anybody struggling with mental health and curious about cannabis, what would they be?
Well, I would encourage you to look into it, look up the research yourself. You can just Google with AI, say, how does cannabis help anxiety? And, start with that. And, don't be afraid. At some point, you can talk to your doctor or nurse or cannabis coach. And don't be afraid to consider it. But remember, the bottom line is, because I am a board certified mainstream psychiatrist, it is premature to use cannabis now for any mental disorder. There is not one mental disorder that cannabis is approved for. So I want to have that on the record. There's a seizure disorder, and mood stabilizers like Depakote, like valproate, carbamazepine. Well, what's wrong with CBD? Epidiolex is approved for seizures, but that's FDA approved, but it's for seizures, not mood stabilization. And there is no mental disorder. I'm going to look in the camera and say it again. There's no mental disorder that cannabis is approved for at this time. But stay tuned, because it's obviously so involved in this in psychiatry and mental health. It should be a great frontier in the future. Thank you.
So thank you so much. Yeah, cannabis helped me to get off of 18 pharmaceuticals, and half of them were antidepressants and anti-anxiety agents. So I am forever grateful for the plant.
Well, and one of my favorite patients, I helped her wean off of Lamictal. She really wanted to get off there. I was having horrible side effects from that. And last time I saw her, she was down to just 10 milligrams of Prozac after, it was, I think it was at 80 at one point. And she's got her life back. She's volunteering with the church. She's wonderfully in love with her husband again, instead of just tolerating and having all of these stories.
You know what? Because that 80 milligrams of Prozac, if you do so much, it makes you stop feeling. You can't feel anymore. Right. So it's no wonder by getting that down that she. So I don't ever go above 40 or 60 unless it's for OCD, real refractory, and I might use 80. But yes, sloppy pharmacology is common. So I'm glad you're able to help, and I hope others can as well. And thank you again for letting me participate.
All right, this has been a great show. Green Nurse, living your best life. And we're going to end with one of my favorite videos, Hope, Inspiration, Growth, and Healing.
One more.
We're here to educate and empower patients to make choices that are best for them. We're also here to decrease stigma around what it means to feel good and be high. Hence the H for hope, I for inspiration, G for growth, and H for healing. The Green Nurse is a holistic cannabis nurse that teaches on the endocannabinoid system and the safe utilization of cannabis and other progressive tools to help people reach a better quality of life.
I was cannabis agnostic for many, many years. And the more research I did, the more I discovered that cannabis is this amazing medicine.
I was told that I had a 4-stage pancreatic cancer. The doctor really told me he couldn't do anything else. He gave me her name, and she called me and she came to my house. She started to give me cannabis. My oncologist was puzzled because he couldn't find the cancer anymore.
All of the learning that we get comes from the Green Nurses group, comes from their support, comes from their guidance. I trust everything that she says.
Simply meet people where they're at. The plant doesn't, stress to grow, so we don't stress to share it. We're healing people.
Cannabis has been used as a medicine for tens upon thousands of years. Here's the big message. Cannabis needs to be federally legal. We need to have laws that are the same across all 50 states that allow access to anyone and everyone who wants to utilize this powerful medicine.